hit right at the hour. So I'll start webinar, wait about 15, 20 seconds, and then introduce you. Good evening, folks, and welcome to tonight's Men's Health webinar. Tonight, we have the privilege of hearing from Dr. Etai Goldenberg. He's a men's health specialist, he's fellowship trained, he's here in the St. Louis Metro. He will cover the signs, symptoms, and treatment options for erectile dysfunction and stress urinary incontinence. The presentation starts with the incontinence portion, moves on to ED, and then we will hear from a patient before having the opportunity to ask questions of Dr. Goldenberg and get those answered. You can actually submit questions anytime during the presentation. Simply move your mouse on your laptop or PC or touch the screen of your smartphone or other tablet device. You'll see a toolbar pop up. Just tap on the chat button that you see, type your question in, hit submit, and again, we will answer those questions at the conclusion of the presentation. Without further delay, I want to introduce Dr. Etai Goldenberg.
Hello all, thank you very much for the introduction, Mike. I apologize, I have a little bit hoarse. I was running after my kids this weekend. My desire today is to talk about two topics that really focus on men's health, focusing on stress incontinence, and then following, we'll talk about erectile dysfunction. Like Mike mentioned, you should be able to ask questions. We will pause halfway and then at the end for questions. The idea of the talk is for it to be an open dialogue. So I really encourage questions. Hopefully that will allow us to continue to answer questions. And if you have a question, hopefully you have other participants that have similar things that they would like answered. Here's a quick slide about me. My name is Etai Goldenberg. I am a urologist here at Urology of St. Louis. Urology of St. Louis is the largest private practice urology group in the St. Louis metro area. We have 27 urologists ranging in specialties like mine of men's health and oncology and female continence. So I did my residency in urology training at WashU in St. Louis. I then moved to New York, where I did a fellowship focusing really only on men's health issues with erectile dysfunction, penile curvature, and male fertility. And then I came back here to St. Louis and joined this practice 10 years ago, really focusing on that type of practice where I really focus on men's health issues. It's what I'm passionate about and patients I really like to take care of. So what I'd like to talk today is starting to talk about male stress incontinence. First of all, what is it, who has it, and what are the causes? So to take a step back, what is the urinary process? If you can see on the slide here, not pictured above here are the kidneys. The kidneys are the organ that makes urine. Urine then it comes down two tubes called the ureters that go and fill the bladder. The bladder is a muscle. The muscle is elastic. So in normal state, what should happen is that that muscle should expand and allow you to hold urine until you want to go. When you do want to urinate, what happens is the bladder squeezes and it pushes the urine through this urethra. There's two things that stop you from leaking urine all the time when you don't want to be urinating. There's a muscle group here inside the prostate and a muscle group here in this sphincter mechanism sitting here at the base of the prostate. These are always contracted or closed at rest, and then they open and relax when it's time to urinate. When there's a problem with the prostate or with that sphincter here is when a man leaks in what's called stress incontinence. So stress incontinence is when someone coughs, sneezes, lifts something heavy, and the force on the bladder pushes the urine to go past that area of blockage. This is common often in women who have had their childbirth that can affect that muscle group. And in men, it's really most common when they had some type of prostate procedure. Most often prostate cancer surgery, but also enlarged prostate surgeries and other pelvic traumatic incidents. There's another type of leakage called urge incontinence. So urge incontinence is when that bladder muscle is unstable. Either the bladder doesn't hold as well as it used to, or just has uninhibited squeezes, where the bladder just squeezes when you don't want it to. And if that bladder muscle squeezes so hard, what can happen is it can squeeze enough to overcome that muscle that's blocking the outflow and lets the urine leak through. This is usually described as this gotta go need, and then your bladder squeezes when you're not ready to. Some men also have what's called mixed incontinence, which is a combination of both the stress component and the urge component. So like I mentioned before, stress incontinence or leakage, like I said before, of coughing, sneezing, heavy lifting, things that cause force on the bladder and then pushes the urine through. This type of leakage, the stress incontinence, is most common in men that had prostate cancer surgery. When men have surgery to remove their prostate, it's very common for them to have leakage in the short term. So almost all men have leakage for the first 3 to 6 months after their prostate's removed. But the majority of men do improve with time, and somewhere between 9 and 16. So I tell most of my patients about 10% of guys have persistent leakage 1 year after the surgery. Other factors that can make this more common, or other things that can cause stress incontinence, are enlarged prostate, radiation therapy, or pelvic trauma. So a diagram of what happens when a man has a radical prostatectomy or their prostate removed. What happens is, if you think about this diagram, this is the bladder laying on its side, different than before when we had a man that was standing up. The bladder sits right here. The prostate sits here, and here's the urethra that runs through here. These nerves run off the side of the prostate. I'll talk about those a little bit more later. This neurovascular bundle is what transmits the nerve endings to help with erections. When a man's prostate's removed, an incision is made here at the top of the prostate, an incision here at the bottom of the prostate. They're disconnecting the urethra from the bladder, and then it's sewn back together. Beyond where the prostate was, the external sphincter should be right here, and that's what's left in place to allow for prevention of stress incontinence. Like I mentioned before, about approximately 10% of guys, that remaining muscle is not sufficient to control your leakage. So what do we have men do if they have stress incontinence after prostate surgery or for other reasons? The first thing is really time, number one. And during that time, especially in that first year, focusing on Kegel exercises, which are pelvic floor strengthening exercises to help that muscle group that's remaining get stronger. Additionally, lots of patients get improved benefit of strengthening that muscle if they do pelvic floor physical therapy with a physical therapist to help you really isolate that muscle and strengthen it. Other things like behavioral modifications, like going to the restroom before activities that make you leak, going to the bathroom more often, reducing how much fluid you take before activities that are going to cause you to have leakage are really common. Other coping mechanisms like clamps and diapers and penile clamps are all options for men that have leakage. Clamps are external things that clamp the end of the penis to prevent leakage. Pads absorb the urine, or an external catheter can collect the urine when it's leaked, so it's contained and doesn't get onto clothing. But long-term, in men that had leakage for that year after their prostate was removed, we start talking about surgical operations that can be helpful to prevent the stress urinary incontinence. So there's 2 surgeries that we focus on for men that have stress incontinence. Number one is a male sling. A male sling is a piece of mesh that goes under the urethra and gives extra support to that muscle that's remaining. This has been shown to really help guys with mild to moderate incontinence. This is an internal piece of mesh that gives support to the muscles that's left behind. So you have to have some muscle that's still there, that has strength and has some control. And if it needs an extra boost, a sling is a really good option. The other option is something called an artificial urinary sphincter. This is a procedure where the muscle group does not work at all, and you need complete reconstruction, allowing for new control. Or if you had a previous operation like a sling that has failed, often also men that have radiation therapy in conjunction with their prostate surgery often do better with an artificial sphincter than a sling. This replicates the function of the external sphincter. It can treat all levels of stress incontinence. This is a device that's controlled with 3 components: a cup that goes on urethra that replicates the way the sphincter mechanism naturally used to work, a control pump that sits in the scrotum, and a pressure regulating balloon, a small balloon that puts pressure that allows the device to function. So in a little bit more detail, if a man comes in and complains of stress incontinence and they're at least 6 months, but hopefully a year after their prostate has been removed, or they've had the prostate intervention that's caused them to have leakage, we do some testing. Usually that's cystoscopy, where we look inside the bladder, and oftentimes a test called the urodynamics, where we look at how the bladder functions. Based on that and a man's description of how much leakage they have, we decide what the best option is for them. Men that have what we call mild to moderate incontinence, so that's usually, in my mind, 4 pads or less of leakage per day. Also, men that when we look inside their bladder do have some control of that muscle when we look inside with the scope, are good candidates for this sling procedure. Because the idea is, well, if you look here on the picture, this small blue area represents that remaining external sphincter external muscle. When you put the mesh here underneath, and then when it's tightened up and then looped through the obturator canal or through the hips, it kind of folds over itself and allows an extra backboard for that muscle unit. It does not cause compression or push on the urethra. What it does is it causes your natural muscle to work better. I usually relate it to a man who tries to do a pull-up and then tries to do a pull-up with someone else helping them by holding their legs. The way the sling works is it really helps by someone holding that muscle, giving it that extra boost. It has a very high satisfaction rate. Over 90% of patients are satisfied with this procedure. Over 90% would recommend to a friend. It is either an outpatient procedure or has an overnight stay. Normally, when I do the surgery, I have patients leave a catheter in overnight, and that's removed the next day. Hopefully, right away, they have improvement of their continence. Men do have to take it easy for around 6 weeks after the surgery. When we put that mesh inside, it needs to scar in or heal in the right place. And so you're really limited with heavy lifting, sports, bending, or squatting for about 6 weeks after the procedure. The other option for long-term solution for stress incontinence is an artificial urinary sphincter. This is a really cool device. The way it works is it has this cuff that replicates the way the sphincter mechanism should work. Like I mentioned before, this is something that is designed for men that either had a sling and did not work sufficiently, or men with severe incontinence or that have no muscle control and they need to replicate the system they used to have. The cuff sits around the urethra and holds pressure at all times. When you squeeze this control pump, it opens the cuff, allows the urine to then drain through the bladder, and then over the course of the next 2 minutes closes back up because of pressure from this balloon, and then allows continence to be restored until you squeeze the button again. If you look here, here is a nice diagram of how the device would function for you. What you do here is you squeeze the pump that opens the cuff. The cuff then is open, the urine can then flow out. Over the course of the next 2 to 3 minutes, it then closes slowly. As this closes back up, it again holds pressure on the urethra, allowing the urine to build up inside the bladder until it's time to urinate again. Artificial urinary sphincter has very high satisfaction. I would say in my practice, these are my happiest patients, men that leak 6, 7, 8 diapers in a day, and we're able to get them to 1 pad or less per day, tend to be overjoyed with the change in their life. This is really a surgery that's best for patients that have a weakened sphincter or no muscle at all. It mimics the healthy sphincter. It's placed inside the body, and it's completely inside the body and regulated by you squeezing the pump. However, there is risk to any type of surgery. With an artificial sphincter, like I mentioned, we are replicating the normal muscle. In doing so, we have to dissect or encircle the entire urethra. There is a risk of injury to the urethra with that operation. And again, that cuff also puts constant pressure on the urethra, and therefore there is a small risk of erosion or pushing of the cuff into the urethra itself. there is a small risk of infection or pain or discomfort with this procedure. The average artificial sphincter lasts around 10 years or so. A male sling also does have risk with any procedure, especially if we're tightening up the urethra and putting that pressure there for the muscle. There is a risk of urinary tension, meaning the inability to urinate after the procedure. Some of my patients do have to have an extended catheter for more than just that first night after the procedure. There is a risk of bleeding, risk of injury, possibility that the device fails, that doesn't work sufficiently for you. As an artificial sphincter and a male sling are surgeries that are treatments for a man that's had prostate cancer. Oftentimes, these are covered by insurance. Before we do a surgery like this, we would verify from your insurance and make sure that you knew what your out-of-pocket coverage would be. This is a very brief overview of these therapies. I'm happy to talk to anyone much more in the office about them. If you want more information, there's fixincontinence.com, which is a really nice resource for patients. You can also go to our website at stlurology.com, which has more information as well. And again, if you do have stress incontinence, I think it makes sense to start with the doctor that you're already that's taking care of you. Most men that have stress incontinence is because of prostate cancer, and therefore you have a urologist that you were already seeing that's following your prostate cancer. I would start the conversation with them. But if you're interested in having a sling or an artificial sphincter, you want to have someone that does a lot of these. That's myself or a couple of my partners that really do focus in prosthetic urology, and this is the majority of their practice and their care. Excuse me. So overall, stress incontinence is a known side effect of prostate cancer therapy and other enlarged prostate conditions. There are many options in turning coping options that can be expensive over time. But overall, if a man has persistent leakage a year after their surgery, we do discuss permanent solutions with a male sling or an artificial sphincter, which can really be life-changing for you. I know that was a quick overview. Mike, did you get questions about incontinence before I move on to the other part?
The questions are ED focused at this point, so.
ED focused, okay. All right. Then should I move on to erectile dysfunction?
Yeah, let's move on to that and we'll wait. Again, folks, you can submit questions anytime. They're using the chat feature. And if you can also do Q&A. So we've got, oh, here we go.
And can you hear me okay? I know, sorry, I'm a little bit hoarse.
Sound is good. Not really a question here, but patient who's undergone prostate cancer surgery and had other surgeries, seen some improvement in incontinence, but at what point after surgeries, if somebody's healed, would you expect their healing to stop? So if it's been 4 years since they've had a surgery, would you expect any additional healing or improvement in incontinence?
So I usually think that if a patient's still improving, they may still continue to improve. And I've seen patients improve for a long period of time. There's also some studies that show that men that feel like they've plateaued on their improvement, if they go and see a pelvic floor physical therapist, there can be significant improvement, approximately 50% improvement of their continence. And so that really tells me that there is always room for improvement with more focused physical therapy and focusing on strengthening of those pelvic floor musculature. And so in my mind, if someone says I'm still getting better, I don't want to stop that trajectory by doing a surgical intervention. So as patients, when you say you've plateaued and we've maximized physical therapy and Kegel exercises, that's really when I start talking about these surgical interventions, if that's a year or if it's at 4 years. But I will say, in addition, I do take the degree of bother to someone from their leakage as the other part. And if someone's improving, but they were going from 5 diapers to 4 diapers, I think it's different than someone who's going from, 1 small pad to trying to get to 0.
Now, if somebody's had radiation therapy, is that something that they may see additional decline in their continence over time?
Yeah, most studies usually think about guys that if they have leakage after their prostatectomy and then they get subsequent radiation, that usually kind of stops the subsequent improvement. So sometimes we'll wait to do radiation until they've regained as much continence as they can. Sometimes we can't wait that long, and the radiation needs to be performed for cancer purposes. And I kind of rely on the prostate cancer specialist to decide on when's best for that. But yeah, the radiation therapy can usually plateau the improvement, and it can cause worsening. Oftentimes, radiation therapy does induce some of that urge component because the bladder can get injured from the radiation therapy to some degree.
Okay, thank you. Now there's a question about urge incontinence and specific treatment options for that.
So urge incontinence is a little bit different. Like I said, that's more hyperactivity or an overactivity of the bladder. First of all, when a man has those components, I try to have them minimize what we call bladder irritating foods and drinks. That's usually, caffeinated beverages and carbonated beverages, and just lots of carbonation and just heavy intake of spicy food can all affect the bladder. So some of it's behavioral, some of it's making sure that that patient goes to the restroom often enough that they keep their bladder empty. But other options are usually medical therapies. There's lots of pills that are available to help with overactive bladder. If pills don't help, there is some benefit also from physical therapy, the same way that we send patients with stress incontinence for pelvic floor therapy. In addition, there are what we call third line therapies, things like Botox into the bladder, interstim devices, and tibial nerve stimulation that can all be helpful. I will admit I tend to send my overactive patients that need those higher levels of therapy to specialists that focus on overactive bladder, the same way I focus really specifically on erectile dysfunction and stress incontinence.
Okay, thank you. There's no further incontinence related questions this time.
All right, I'm gonna take one more drink and then I will get ready for erectile dysfunction. All right, you ready for me?
I'm ready.
All right, so erectile dysfunction, understanding what the disease state is and what the treatment options are. So erectile dysfunction, who has it, what it is, and what can cause it. So to start off, erectile dysfunction, in my mind, is the persistent inability of a man to achieve and maintain an erection that's firm enough to have sexual intercourse. How common is this? And so depending on which studies you look at, for the most part, this is much more common than many guys think. 1 in 5, so 20% of Americans over the age of 20 experience some ED, and over half of men over the age of 40 do have some degree of ED as well. So again, very, very common, approximately 40 million American men. When I think about the erection process, if you think about what's happening, first of all, it starts with stimulation in the brain. That's really being in a comfortable environment, an environment that works for you. Low stress also often does help you with your mood. In addition, having the appropriate amount of testosterone. Testosterone is the hormone that helps with sex drive and desire and libido, gets that signaling starting in the brain. Once that signaling goes to the brain to go down to the penis, you have to have normal nerves and normal blood vessels that then send that signal from the brain down to the penis and send the blood flow from the heart down to the penis. When I think about the penile anatomy, I think of the penis in the most simplest forms of 3 tubes. There's the 2 red tubes that you see here. Those are the erectile bodies. It's a pair of tubes that are what fill with blood when you get an erection. There's an artery that runs through though that brings the blood inside, and there's lots of sinusoids and veins that fill with the blood when you want to get and maintain your erection. Underneath here, this is the urethra. That's the part of the penis that you pee through. When a man gets an erection, the artery brings blood into the penis. These erectile bodies here, seen in the red, then fill with blood, and then the veins in there collapse against a sheath here, this outer part of the corporal body, maintaining the erection until you've completed sexual activity. So what are the most common causes that cause this process really not to work the way it should or it used to? And like I mentioned, a lot of this is a blood flow issue where blood has to flow into the penis. And so not surprising when I look at this pie chart, 40% of men that have erectile dysfunction issues, it's because they have blood flow issues or vascular problems. Also, diabetes. Diabetes is a really common disease process, which I'll talk about more, that can affect nerve endings and affect blood flow. Different medications, especially high blood pressure medicines, which can affect blood flow, can affect a man's ability to get an erection. Also, different medicines that affect nerves can also affect the way that you get an erection. And finally, pelvic surgery, like prostate cancer surgery, is a very common reason we're also men with erectile dysfunction. So to delve a little bit into kind of each of these most common causes for erectile dysfunction, a man with diabetes has a higher chance of getting erectile dysfunction, and it often happens much earlier in diabetic men, 10 to 15 years earlier than in non-diabetic men. In addition, the most common treatment that we start with men with erectile dysfunction are pills. And unfortunately, diabetic men, because of some of the neuropathy associated with it, have a less of a response to pills than men that do not have diabetes. So oftentimes diabetic men will say that their erectile dysfunction is more severe than the general population. Factors that increase the odds of a diabetic man having erectile dysfunction are their age, the number of years they've had diabetes. I think most importantly, their glycemic control, how well they've controlled their diabetes over the course of their disease, and the presence of other types of diabetes complications like microvascular disease and neuropathy. Those men are more predisposed to getting erectile dysfunction. In terms of heart disease, when I think about the amount of blood that has to flow into the penis in order to get an erection, it's transmitted through this penile artery. So there's a pair of penile arteries, one for each of the corporal bodies. This is about 1 to 2 millimeters in diameter. So these are actually very small arteries. You compare that to the coronary artery, which is the artery in the heart, that if someone's having a heart attack or has had a stent placed, this is what got narrowed. Or the carotid arteries is what narrows when a man has a stroke. So in my mind, any patient that has had a history of heart disease, has a history of heart attack, a history of stent, I know that this artery in the heart has been narrowed. Almost for sure, the penile artery, the artery that's about a third the size of that artery, has also been narrowed and influenced in some degree. So a man with heart disease, or how do you reduce your risk of heart disease? Exercise, diet, not smoking, losing weight, reducing your stress can all reduce your risk of heart disease or vascular flow, and also reduce your risk of erectile dysfunction due to blood flow. As I mentioned at the beginning, low testosterone is a really common thing that's associated with erectile dysfunction. So testosterone is the hormone that's produced from the testicles. The testicles have two jobs. They make sperm and they make testosterone. The testicles make testosterone, but as a man ages, they often make less testosterone. And about 4 in 10 men over the age of 45 do have a drop in their testosterone. Low testosterone is associated with lots of other causes that we also see for erectile dysfunction and other causes, like being overweight or having diabetes or having high cholesterol or high blood pressure. When a man has a low testosterone, this can often cause them to feel tired or run down. It has more difficulty losing weight. You can feel that you have poor concentration, decreased memory. And on the sexual side of things, you have reduced sex drive or a lower libido, and also have erectile dysfunction. So in order to diagnose a man with low testosterone, it's a blood test. And so when men come to see me and say that they have erectile dysfunction, or men that come and see me and they say they have a lower sex drive or less desire, we check a testosterone level. A testosterone is most accurate if it's checked in the morning. So we check testosterone levels normally before 10 a.m. And we would check a testosterone on 2 occasions in order to really not only check it once, but really measure twice before we proceed with any type of treatment for low testosterone. If a man has low testosterone, and we discuss the kind of pros and cons of giving testosterone therapy, which would be hormonal manipulation or medication to raise their testosterone levels. There are some pills that can be given to kind of trick your brain to send increased signaling to your testicles to make more testosterone. Those are off-label therapies like Clomid or anastrozole, which we often give to men that still want to have more kids. But if a man says, I don't want to have any more children, and they have a low testosterone diagnosed on 2 occasions, we usually give testosterone replacement therapy. There's been a real boom of therapies out there for low testosterone, and those include gels that you can put on your skin once a day. There is a patch you can put on your skin daily. There's some new pills, which are twice a day, which have really come out in the last couple of years that have been shown to be safe to raise testosterone. Also injections that can be done weekly, or pellets that go under the skin, usually every 3 to 6 months. Next topic I'll talk about is erectile dysfunction and prostate cancer. This diagram should look familiar. It is the same one that we talked how a prostatectomy is done, where we make an incision at the top and the bottom of the prostate and then bridge that gap by resewing the urethra to the bladder. In order to remove the prostate, these nerves that run here, this neurovascular bundle, that's what transmit the signal from the brain down to the penis in order to allow for an erection. When that neurovascular bundle is removed off the prostate in what's called a nerve-sparing prostatectomy, often that there is some mild injury or at minimum a neuropraxia, meaning those nerves are stunned from being moved off the prostate. The literature would say that half of men who undergo treatment for prostate cancer will develop erectile dysfunction after their therapy. So it is very common for me to see patients in my practice who had their prostate removed or had radiation therapy to their prostate and then develop erectile dysfunction. Erectile dysfunction and Peyronie's disease. So what is Peyronie's disease? This fibrous plaque that you see here on the outside of the erectile body, this is a Peyronie's plaque. So what happens is when a man is predisposed to getting abnormal scar formation, which is approximately 1 or 2 out of every 10 men, and they have some mild trauma, what happens is that trauma then causes too much scar to form in here. And then that plaque becomes less elastic than the rest of the penis. So if you can picture this scar here that does not stretch the way the rest of the erection does, and at rest, the penis looks normal, but with an erection, that plaque does not stretch, and therefore you get curvature in the angle where the plaque is present. It can cause difficulty with sexual activity, it can cause pain with sexual activity, or inability to have penetrative intercourse. Oftentimes, this is confused with erectile dysfunction. These are separate things. However, they do really fall in the same patient population, and there's many men that do have erectile dysfunction and Peyronie's disease. If you have Peyronie's disease, I usually will talk to a man separately about what their curvature is causing difficulty with and what the firmness of their erection is causing difficulty. If their issue is mostly penile curvature, we do give injections of a medicine called Xiaflex. Xiaflex is the only FDA-approved medication to break down those plaques. That's a series of 8 injections in the office to break it down. There are also, in addition, different stretching mechanisms that can be used to stretch that plaque out. There are surgeries that can be done to allow for correction of Peyronie's disease or penile curvature. Plication procedure is the most common procedure that we do that shortens the opposite direction of the plaque. We can also incise or excise by removing that area of plaque and putting a graft in. Or if a man has erectile dysfunction and penile curvature, we can offer a penile implant, which I'll talk about a little bit more. Okay, so what are the options for a man that comes in with erectile dysfunction? So I think number one, the first thing is bring it up with your physician or your practitioner and beginning the conversation. Oftentimes nowadays, since I've been in practice the last 10 years, I think more and more primary care doctors, family practitioners are really comfortable talking about erectile dysfunction because the treatments are much more available. These are things like Viagra and Cialis and things like that. Lots of primary care doctors feel comfortable doing that and checking testosterone. So I would start there. If those things don't work, or if you feel more comfortable coming to see a urologist, there are urologists in general that can take care of erectile dysfunction. And then there's people like me that are prosthetic urologists and some of my partners that really focus their practice on these options. And so in general, what are the options for erectile dysfunction? That starts out with oral therapies or pills that can help bring more blood flow into the penis. wave therapy, which are pulse waves to the penis that allow additional blood flow. This is a non-FDA approved therapy. Injection therapies, which are a small needle into the penis to deliver medicine directly into the penis to allow for blood to flow in. Suppositories, which are a small pellet that goes through the urethra. A vacuum erection device, which is a cylinder that goes over the penis and pulls blood inside. And finally, a penile implant, which is a surgical procedure where we replace the inner parts of the penis with cylinders filled with saline that can allow for an erection. So in a little bit more detail, what are these options? So oral therapies or pills to allow for erections. These, the most common, like I said before, are Viagra and Cialis, but there's a bunch of other ones in the market, including Levitra and Stendra and Staxton. They all work in a similar mechanism of action, which is called a PDE5 inhibitor. The way it works is it allows the blood vessels in the penis to be more excitable. So if you take a pill like this and don't engage in any type of sexual activity, nothing different would happen. But with sexual activity, it allows the blood that comes to the penis to stay in the penis longer and allow for a better erection and a more firm erection. Different medicines can be affected by food, especially Viagra and Levitra can be affected by food. So it's really important to take those medicines on an empty stomach. They also work better without alcohol in your system. Certain men can't take these medicines. Most commonly, men that take nitroglycerin for chest pain aren't candidates for pills. In addition, some men do have really difficult side effects, including headaches or stomach aches or stuffy nose. Shockwave therapy, I'd like to mention, I know there's lots of press about shockwave therapy. This is a non-FDA approved therapy, but has been shown to be very safe. The way this works is these pulse waves go to the penis. They allow the blood vessels that are in the penis to be irritated in a way that can cause them to regrow in what's called neovascularization and also repair some of the damaged blood vessels. This is done in the office, about 20 to 30 minutes. The way we do in our office is a man comes in for 6 separate treatments, usually twice a week for 3 weeks or weekly for 6 weeks. And the average guy does get some improvement of their erectile function. We really found this to be best for guys with mild to moderate erectile dysfunction, and especially mostly for men that have what's called vasculogenic erectile dysfunction. So better for men whose erection problem is because of poor blood flow, not patients that have had nerve injuries like diabetes, or most especially guys that have their prostate removed. A vacuum erection device, the way this works, if you see in this picture here, this is a cylinder that goes over the penis. You either press a button here that mechanically battery operated pulls the air out, or there's a different manual option where you squeeze a pump that allows the air to be removed from the tube, and therefore by causing a negative pressure space, blood is then promoted to pull into the penis. When the penis is then full, you push the band off the tube onto the base of the penis that allows you to maintain your erection for sexual activity. It's highly satisfactory. About 70% of guys get a good erection with this. However, there are complaints, most commonly blocking of the ejaculate because of the ring, some bruising from that ring, or discomfort, or some feelings of numbness and coldness with the erection. I do have many patients that are very happy with this device. Also, I do have patients that say that the side effects are too much and they don't enjoy sexual activity because of it. Urethral suppositories are probably one of the least common things we'll use, partially because of cost. But the way this works, it's a prepackaged apparatus that needs to be refrigerated. It comes like this, and when you do is you put this applicator into the urethra, into the urinary stream, and then push this little pellet into the urethra. That pellet then gets dissolved and absorbed by the penis, promoting the blood vessels to then dilate. Because it's a little bit less specific and it causes other blood vessels to dilate, it can cause some lightheadedness and dizziness. Some of the adjacent blood vessels dilate and too much blood flows into the pelvic area, and can cause a drop in blood pressure. So when men try this for the first time, have them come to the office and we check their blood pressure to make sure A, that they're comfortable using this apparatus, and B, that they don't have too much of a drop of their blood pressure. More commonly than the suppositories, we often will send guys and set them up for injection therapy. Injection therapy is a small needle that goes into the side of the penis and delivers medicine directly into the penis that allows the blood vessels to dilate. Normally, the injection occurs within 5 to 10 minutes. You should get a sufficient erection for sexual activity. Most guys maintain an erection about 30 to 45 minutes. The most common side effects are pain and discomfort from the injection site. In my experience, about 60 to 75% of guys are happy with these injections. The biggest risk in my mind is a priapism or prolonged erection. The idea being that this medicine is much more potent than other things like Viagra and Cialis. And if you give yourself a shot like this, there's a higher chance of having a prolonged erection. So again, the first time that a man does a shot like this, we do it in the office and test their response. And finally, I want to talk about a penile implant. A penile implant is a permanent solution for erectile dysfunction. It's highly effective and highly efficient. The way it works is we replace the inner parts of the penis with these cylinders. They're controlled by a pump, and there's a reservoir of fluid that sits in the low abdomen or in the pelvis that holds the fluid for the erection until you squeeze the pump in order for the erection to occur. There's different types of penile implants. These include devices that are in place and that you can bend up and bend down at any time. Two-piece devices, which are always semi-firm, and then you squeeze the pump and to get 100% rigidity, or the most common device we put in, which is a AMS 700 or a three-piece device, which has two cylinders that go in the penis, a pump that goes in the scrotum, and this reservoir in the pelvic area. You can see that this device compared to the other ones is yellow in color because the AMS 700 device is coated in antibiotics. That antibiotic coating reduces the risk of infection of a penile implant. So the way the device works, we should see here in a second, is the device is concealed inside the patient's body. The two erectile bodies were replaced with these cylinders, and you have the pump that sits in the scrotum. When you're squeezing the pump, you're shifting the fluid from the reservoir into the cylinders, allowing for an erection to occur. You can then maintain your erection for as long as you'd like, and then you press a release button. Once that release button is pressed, the fluid then exits the cylinders and goes into the reservoir, and then is there ready for your next use. If you look here, here's a patient with a penile implant in place. You see he pulls the pump here in a way that he can identify it in the scrotum. You can squeeze the pump. By squeezing the pump, you're shifting the fluid from that reservoir into those cylinders, allowing for the erection to occur. And then, as you can see, it is concealed inside the body, very unnoticeable. And then you bring the pump back up to the skin. You press the release button, which is right there under his index finger. You press the button, it opens the valve, allowing the fluid to then exit, and then allowing for a flaccid penis again until the next time. You can squeeze the penis there a little bit to get the rest of the fluid all the way out. A penile implant is very highly satisfactory. I tell my patients it's about 90 to 95% satisfaction for them and for their sexual partners. It is a surgical procedure. It's an implanted device inside the body. And so there is risk. The biggest risk, like I said, is infection, which is about a 1 to 2% chance. And that's why we prefer to use these devices that are coated in antibiotics to reduce that risk to that 1 to 2%. In addition, there's a possibility that you have the device placed, you don't like it, or you have problems with it, or requires revision surgery. That said, it has a high satisfaction and for the patient and for their partner. Approximately 500,000 penile implants have been placed since its inception. Penile implant surgery is often covered by insurance, and we would get verifications of your insurance before we proceeded with your surgery. edcure.org is a really nice website that has a lot more information. I know I'm trying to go through this quickly. If you would like more information, again, you can go to edcure.org or to the STL Urology website in order to get more information. I'm happy to answer more questions about this, but I'm very lucky to have Cliff here who can talk about his experience, and then maybe I'll answer questions at the end.
Sounds great.
Perfect.
Good evening, everyone. Thanks for coming to the presentation. When I was 58, I was diagnosed with prostate cancer. And even though the doctor said it was a slow-growing cancer, I decided I wanted it removed before it went anywhere else in my body. As a result of the prostate cancer, I ended up with ED. I went back to my regular physician and they put me on Viagra. Unfortunately, I was one of those people that had terrible, terrible headaches from the Viagra. So they transferred me to Cialis and then Levitra, and nothing made a difference. My headaches were so bad that when I took the medication, I would have to lay down and I just could not get up and have intercourse. It was one of those things that I would never thought I'd say to my wife, not tonight, honey, I have a headache, but they were terrible headaches. So I went back to my physician, and he suggested the external vacuum device. And I will say, as Doc said, it does work. There are a couple of drawbacks to it. One of the biggest drawbacks to it is the fact that when you put that tourniquet on, your penis kind of gets a little cold, turns a little blue, and it's not very inviting to your partner. Also, taking the band off is kind of hurts when you get past the shaft and over the head of the penis. So after using it for about 4 months, we decided that was the end of it and we didn't do anything. Just didn't use it. At that point, I did not know what else was available. So I went into a major depression because I lost my manhood. And I stayed in that depression for a little over a year. Luckily, I got an invitation to a presentation like this. And I learned about the other methods, the other treatment therapies, the little mutes, pellets, the injections, and the IPP, or the inflatable penile prosthesis. My wife and I talked about it and decided that the inflatable prosthesis was the best thing for us. Well, the day after my 60th birthday, I had the prosthesis implanted. I went home the next day. I did not have a lot of pain. I did have discomfort, but I was able to just take care of the discomfort with Advils and didn't have to worry about taking the barbiturates and stuff that they gave me to take care of the pain. I really didn't have much. After 2 weeks, I went back to work. And at 3 weeks, I went back to the doctor. And the doctor, the urologist, prosthetic urologist, showed me how to use the prosthesis. I used the prosthesis for a week. And then once I was comfortable with it, about the 6th week, we decided to try it and have intercourse. And lo and behold, it worked. What came from it was the fact that not having intercourse for so long, really, we lost a lot of intimacy. And this brought back the intimacy. I had the implant. First one I had lasted 14 years. It never failed to give me a solid, rigid, rock-hard erection. And it worked all the time. At the end of 6 weeks, when I started having intercourse again, I went back to working out at the gym with my friends. We showered together. They have absolutely no idea there's anything inside me because it's all internal. One of the remarks my wife has made over all the years is that had she not known me prior to the ED, she really could not tell that there was something artificial inside my penis at all. It looked perfectly natural. So I've had that one for 14 years. After 14 years, it finally gave out and I had it replaced. I had it replaced 3 years ago. I'm 77 years old. If I last another 14 years and I'm still going, I'll have it replaced again. It's simple as that. People ask me specific questions about it, and the most interesting questions are, what happens when you go to the airport and you go through the metal detector? The answer is nothing. It doesn't go off. My knees do go off because I do have 2 artificial knees. And then I don't know how many people have ever had the issue where they take you over to the side and they run this wand up and down your body, and then they go on the inside of your thighs and around your crotch. Nothing happens. So it's perfectly innocuous. It does not exist as far as they're concerned. Other people tell me, does it stop you from having scans like PT scans, PET scans, MRIs, things like that? The answer is absolutely not. The biggest question they ask me is, does it affect your urination or anything that has to do with your bladder? The answer is no. It has no effect whatsoever. So basically, my best advice to anybody could be, ED is always thought of as a male issue, but I really think of ED as a partner's issue. And I think when you go to a doctor, an ED doc, that it's best to take your partner with you so that they understand what is really going on. And I can't tell you how many people have told me, my wife thinks I'm having an affair. I don't love her anymore. I don't find her sexy. That's why I'm not having intercourse with her. And that is the farthest from the truth. And so when you get your partner involved in what's really happening, I think your results and your partnership with your partner becomes much closer, and you get back all that intimacy that you lost. So at this point, I'll turn it back, Mike, for questions for Dr. Goldenberg.
Yeah, we've got several questions here. The first one is about, so there's a lot of businesses, I believe there's 19 of those in the St. Louis metro area that talk about wave therapy, P shots, and some other interventions. Are these legitimate interventions, and are these businesses legitimate? That's the question. So the ones that are advertised that you see on TV. Thank you. Yeah.
Sorry, I was muted. Okay, so the wave therapies that are advertised on TV, are they legitimate? I think it depends on where you're going and what unit they're using and who's supervising. There's definitely a variability on the types of wave therapy that can be given. I think you should verify that it's a physician that's supervising the administration of the wave therapy. Number one. And then 2, I think that some of those therapies that are offered by those clinics, like you mentioned, the 19 surrounding clinics, do they offer legitimate therapy? I think a lot of them do offer legitimate therapy. Unfortunately, they really don't take insurance. They're cash only, and often will charge very high prices for similar things that you can get in our office for a fraction of the price. Finally, those places don't really offer kind of the whole gamut of therapy where they won't offer penile implant. And so I always worry that patients that go to a place like that, just part of my job with these presentations is to say that there are all these options out there, including penile implant surgery. And a penile implant is definitely not for everybody, but I think it's important that you know that it's available.
Thank you. This question, I'm not sure how to ask it exactly, but erections after prostatectomies. Maybe this person's asking, is it common for people to lose their erections after that prostatectomy? And then maybe what can be done if it doesn't come back?
So approximately 50% of men don't regain their erectile function after their prostatectomy. So it's very common not to have erectile dysfunction after your prostatectomy. In addition, men who have their prostate removed do have a high chance of having penile shortening, because in order to bridge that gap between the urethra where the prostate used to be, you do have to pull the urethra in. So the average guy does lose a little bit of length of their erection with their prostate removal. In addition, there's a risk of developing Peyronie's disease because of prostate cancer therapy. And so I think to answer your question, yes, it's very common to have erectile dysfunction or other sexual issues related to prostate cancer treatment. Also change in ejaculate, and men that have their prostate removed have a dry ejaculate. There's no fluid that comes out, which is associated with having your prostate out. Was there a different part to the question too?
No, those were my own added additions to the question. So I think that's a very good answer. And then we've got.
Do you want to add anything?
No.
There's a question about getting implants for both incontinence and for erectile dysfunction. Is that possible?
Yeah, I do that. I do that a fair amount. Like I said, men that present, they come to me after they've had their prostate removed, and they have complaints of both stress incontinence, which is related to prostate cancer treatment, and erectile dysfunction related to their prostate cancer treatment. We do have lots of patients that will do it separately. Well, we'll do a sling or an artificial sphincter and then subsequently do an implant, or vice versa. But I do have patients that we will offer both those therapies at the same time, so that to minimize the amount of time you need to recover. So you can have a sling and an artificial sphincter, or a sling and a penile implant, or an artificial and a penile implant in the same setting. It is a longer surgery to do it that way, but you only have one recovery time.
Now, it's another question about wave therapy, specifically about the cost of it, if it's covered by insurance, and then if there's different types of it, and if there are, what type that you use in your office.
Yeah, so there, so number one, the wave therapy is not FDA approved, and so because it's not FDA approved, it cannot be run through insurance. Insurance companies won't accept that as an option, even though there are a fair amount of studies that will that have shown that to be beneficial, especially for the right patient population, and it is approved in Europe for the use of erectile dysfunction. Because it is not approved in the United States, different places can charge kind of whatever they want for that therapy, different than things that are run through insurance. We charge at our office, I think it's $1,800 to do the 6 treatments. I think if you look online, lots of other men's clinics, I think that there is a huge variety on the cost that you'll receive. Was that the question?
Yep, and the question about, are there different types, and if so?
Oh yeah, so there are different types. There's something called acoustic wave therapy, which is a less, which the therapy doesn't permeate it as well. It doesn't have as much of a as much therapy delivered in terms of how much is delivered. There's really 2 types of wave therapy. There's a kind that can be given without supervision by a medical practitioner, and wave therapies that need to be supervised by a practitioner. We have that type in our office. That's why there are certain wave therapies that can be sold for patients to do themselves at home, or at some places that offer wave therapy don't have a physician or a practitioner that's delivering, and those therapies have not been shown to be helpful. So you need to go to a place that has supervision from a provider.
Thank you. No, there's a question about, for somebody who's not had an erection for a long time, this example, 15 years, is it still possible to treat that person's erectile dysfunction if it's been years or possibly over a decade?
Yeah, definitely. I've had patients that have come to me 20, 25 years after their prostatectomy. They came to a webinar like this. They haven't had any erection during that time period at all. And then we've subsequently given them treatment either with injection therapies or given them treatment with the penile implant, and they've been very satisfied. So there's really, there's not a time period where that this is no longer an option.
Now, is there an age limit on getting your ED treated, and is there an age limit on getting an implant?
In my mind, age is just a number, and a lot of the ability to have any type of treatment really, I think, is more in association with someone's overall medical status. To answer your question about a penile implant surgery, to have a penile implant is a surgical procedure. It's done under general anesthesia. And so you would need to be cleared by your primary care doctor or your cardiologist in order to have a surgical intervention. If you take blood thinners, you need to stop those blood thinners for the operation. I've done penile implant on patients for as young as in their 20s to 30s to men as old as into their 90s. And it really has to do with their overall functional status and not their age. In addition, men that can't have anesthesia and want sexual function would still be candidates for the other options like vacuum devices and injection therapies. I have lots of patients that say they can't stop their blood thinners, and they do perfectly fine with injection therapies, even though it's a small needle that goes into the penis. There's not significant bleeding associated with that. And I do have patients that can't undergo penile implant surgery and are satisfied with the other options.
Thank you. Now, this is a good question, I think, for both of you. Can you discuss in more detail what the recovery after an implant is like?
Yeah, so I think in general, when I do a penile implant surgery, the man comes in for their surgery, or maybe even to rewind before that, I see them in the office at least twice, once as a pre-op consultation. I always see patients about a week or two before their surgery and talk to them again about the procedure, start them on some antibiotics and a wash to reduce the risk of infection. Then they have the surgery either as an outpatient or just an overnight stay. They have a wrap and a catheter in that stays in overnight. Lots of guys will go home and just take the catheter out themselves the next day at home. You need to take it easy really for 2-3 days, but I recommend not doing any heavy lifting, sports, things like that for about 2 weeks after surgery. Most guys tell me they do have some swelling and some discomfort for about 2 to 3 weeks afterwards. You can't engage in sexual activity for 6 weeks after the operation.
Yeah, I would concur with you, Dr. Goldenberg. I really was more discomfort than pain. I do have a couple of suggestions for people who go through this. One of the things I found out is while you have a little swelling, if you are somebody who sleeps on your side, it's good to put a pillow between your legs so you don't squash or smash your scrotum. Otherwise, I guarantee you will not sleep. But otherwise, the pain really was not significant. The ability to urinate was not a problem. So basically, it really is based on your pain threshold, I think. But after 2 weeks, all the swelling went down and everything was basically back to normal. Just trying to learn how to use it correctly and to actually then be able to use it.
Thank you. Now, final question here. It's a general question about if Viagra can help with ED, but maybe a better question, more broad, is your process for just assessing and working with the patient, Dr. Goldenberg. What does that look like? How do you determine what the best treatment option is for somebody to try initially?
For erectile dysfunction?
Yes.
So in my experience, a guy comes in with erectile dysfunction and I talk to them about their with the initial assessment, just to hear about their medical history, what else that they've done. And then part of it is I check their testosterone level and just make sure that they don't have any other medical illnesses that we need to address first. Most men, I would give them a trial of a PDE5 inhibitor like a Viagra or Cialis to see if that works well for them in starters. If a man has no other correctable issues, if they feel like their issue is really solely getting their ability to get an erection and they failed the oral therapies, that's when I start talking about these other options. And then the truth is I present them all to the patient and about the pros and cons of them, maybe in a little bit more detail than we talked about today, and then let the patient choose on what they think is an appropriate next step for them. Some guys, would say that I really don't want to do surgery, and we don't really go down the penile implant path. I have some patients that say they're really scared of needles and they'll never do injections, and then I don't force them to do it. It's really the patient's choice on what they think is most appropriate for them and for their partner.
Thank you very much. We do have a couple of very individualized questions. We're over the originally proposed time, so I'll leave it up to you, Dr. Goldenberg, if you want to address those.
I'm here. I'm happy to answer a couple more questions if you think they'd be helpful.
Okay, so for someone who's seen considerable shrinkage to the size of their penis after years of ED, are they still eligible for an implant?
For sure. Men that have shrinkage of their penis, oftentimes I'll have them get a vacuum erection device. And if they use it regularly for some period of time, usually twice a day for 3 months before their penile implant surgery, they can get some stretching of the penis that allows for a bigger implant to be placed. That said, I don't think that there's really a size characteristic that makes a penile implant not an option for a man, but it's more based on what their desire would be for it in terms of length. So no, that would not be a reason not to do a penile implant, is because of shrinkage of length, but there are things we can do to try to optimize the most length in the largest implant we can implant.
And there's a question. So someone has skin growing over the head of their penis that limits their ability to accurately urinate. Is this something that an implant could address?
Maybe. I think that's something that would probably need to be examined in the office, unfortunately. It's possible that that patient needs a circumcision revision or needs some other reconstructive things. Or it's possible that a penile implant would be helpful. I think that's kind of a case to case and probably would needs an examination to let you know what that patient's options are.
Thank you. No further questions this time. How can somebody get a hold of you what's the best way to do that?
Yeah, so my understanding is that at the end of this webinar, everyone that signed up will get an email that should have a call to action and an ability to make an appointment if they are interested. It should have the contact information for my office, but that they can go on our website, stlurology.com, to make an appointment if they'd like independently, or you can call the office 314-567-6071. I do have offices in St. Louis. It's on the Outer 40 Drive near Missouri Baptist Hospital. In addition, I do have an office over in Illinois at Anderson Hospital in Maryville. I also have a few partners that also specialize in erectile dysfunction, and they have offices both in the Missouri and Illinois side.
Thank you. And yes, to confirm, everyone will receive an email tomorrow with a link to this webinar recording, that contact information, phone number, and website, as well as the locations that you practice. I will leave it to you guys if you have any final parting words for the audience.
Just thank you all for tuning in. I appreciate your time, and really nice night. And I hope this was informative and helpful. And I look forward to seeing you. This was helpful.
All I can say is any of these treatment options will certainly change your life.
Thank you both so much for sharing all the information tonight, for taking the time to be here. Appreciate you both, Dr. Goldenberg and Cliff. And thank you everyone for attending. This concludes tonight's Men's Health webinar.
Thank you so much.